All of us knows that the trabeculectomy is the gold standard procedure for anti-glaucoma surgery. And as I said earlier, that it remained over here for past 50 years and still it has many more years to go. But still all of us knows that our endeavor is to achieve the target intraocular pressure which persists for a very long time. We need a long time survival of the trabeculectomy. But all of us are familiar that trabeculectomy, like the glaucoma most often is either overdiagnosed or underdiagnosed. Similarly, the trabeculectomy either fails or it overfilters. So when it fails, what you have to do, Sunil has already spoken to you. I'm going to talk about when it overfilters, then what to do, how to proceed. That is what our objective is, to have a good ideal bleb. But very often we'll end up with an overfiltering bleb or a leaking bleb. It could be either in the early postoperative phase or maybe in the late postoperative phase. With the non-judicious use or overuse of antimetabolite, this problem is increasing days by days. And it is not that we get the overfiltering bleb in the early postoperative phase, but even 5 years, 7 years, 10 years down the line. I have performed a trabeculectomy about 20 years back. Now the patient, a couple of weeks before, the patient has reported to me with a leaking bleb. That is because of the non-judicious use probably, or the overuse of the antimetabolite. And maybe because of the judicious use, but the antimetabolite continue to work for very long time and it continue to necrose the scleral fibers. So because of that, we have lots of sequelae in the problem. The hypotony, the hypotonous maculopathy, shallow anterior chamber, formation of the choroidals, cataractogenesis, the blebitis, endophthalmitis, and so on and so forth. So early recognition of the leaking bleb or overfiltering bleb and a proper treatment is highly essential. When you have a overleaking bleb or a overfiltering bleb or a large bleb, the biggest problem the patient faces in the early phase is the dysesthesia. Patient comes to you with the symptoms of large bleb. There is an enhanced tear film breakup time, and because of that, the patient has a foreign body sensation, stinging, watering, lots of SPK formation. So how would you treat? Obviously, this large bleb causing a dysesthesia, you would not treat surgically. First, you would like to treat medically, and the option is to give the frequently topical lubricants. And many of the patients, they do well for a pretty long time. But if they don't do well, then what to do? Then you have to regress the size of the bleb. The easiest solution to regress the size of the bleb is use the argon laser. That is what I have painted the bleb with the trypan blue, put the large size of the spots with the argon laser, and this bleb has regressed well. But it never happens always. Many a time you rupture the macrocyst and the bleb becomes a leaking bleb. So it has its own problem, but if it works, then it's the easiest procedure. Sometimes you can inject the autologous blood. In my hand, the autologous blood injection works only in 5 to 10% of the patient to regress the size of the bleb and to regress the macrocyst. But yes, it is one of the easiest process. You take the blood from the antecubital vein, just inject 0.1 cc of the fresh blood into the substance of the bleb and see that the blood leaks into the anterior chamber. And some of the patient, if you are lucky, then they may do well. The other method, if you want to regress the size of the bleb for the dysesthesia, is put up the compression suture. I have done in many cases, but the problem with that, once you put the compression sutures, the size of the bleb goes down, but the suture becomes loose and you have to remove the suture. And once you remove the suture, again the bleb comes up. So the problem is the same. So it doesn't work so well in my hand. I will show you another case of the leaking bleb. The patient has reported to me in a very early post-operative period. When it happens with you, when the patient comes to you in the early post-operative period with a flat bleb, what would you do? You would do the pressure patching for a couple of days. If the bleb doesn't form, then what next? Because you cannot afford to have a flat anterior chamber for a longer time. So I did the revision surgery of this patient and see what was there. When I put the bridle suture, opened the conjunctiva again, I was surprised that the conjunctiva was sutured with a vicryl suture, not with the standard tenno nylon. And then I raised the conjunctiva, and still, I was surprised to see that the deep scleral flap, the scleral flap was sutured with a 6-0 vicryl, and that too only 2 sutures were applied. So I cut that sutures. I saw the deeper ostium. It was very well made. So again, I did a proper suturing, the proper closure of the scleral flap and the conjunctiva. And this patient I have followed up for more than 10 years and has done beautifully. And the pressure was controlled for a very long time. Let me go to some other cases. I will show you some couple of more surgeries. So early postoperative period, you can treat the patients conservatively. But if you have a patient like this who has a lots of macrocyst and a low intraocular pressure, the hypotonous maculopathy, then what? You don't have any option except to do a surgery, the revision surgery. That is what I did for these patients. I did the revision surgery. I did the debulking of this overfiltering bleb, and it was very easy for me. When I did the debulking, I saw there was a small spot which was leaking. There was a small area of scleral necrosis. So I just put a single suture over there. That was sufficient, and the patient did very well post-operatively for a very long time. I have lost this patient for follow-up for last 3-4 years. Another patient, that is what you get in majority of your patients. Again, in the same kind of a patient, I did the debulking, but there was a huge area of the scleral necrosis. That is all because of the non-judicious use or overuse of the antimetabolite, or even in the high or moderate myopes, when you use the antimetabolites, then this problem may occur. So there was a large area of the scleral necrosis. If you have a large area of scleral necrosis, then you have a limited option in your hand. Either you raise again a partial thickness scleral flap, that is what I did over here from the posteriorly, and you cover that scleral necrosis area and resuture it, the patient do well. But still, if it is a larger area of necrosis, then you do not have any other option except to put the scleral, the donor sclera from the cadaveric eye. I will show you another case. It's a leaking bleb. There was one large cyst which was leaking. Obviously, you cannot leave the patients with a leaking bleb. There was a hypotony, though there was not a hypotonous maculopathy, but only a single spot which was leaking. So again, I did the revision of the patients. I excised the bleb, and I saw that there was an area of scleral necrosis. So again, I did the rotational partial thickness scleral graft in the same way. This patient also did well. Recently, I did one more patient, but for that patient, the pressure went up to 40 millimeter of mercury, and still I am treating the patient medically. Probably that patient would require another surgery. I will do it. So that thing you have to keep in your mind, that all the patient would not have a normal intraocular pressure for a longer time. You may have a problem of a high intraocular pressure. So if you have a patient with a large cystic bleb with the macrocyst, then all these patients are sitting on the tip of volcano and they are prone for a blebitis or a development of endophthalmitis. So you have to be very careful. Always instruct your patients that not to rub their eye rigorously, avoid swimming, avoid exposure to the eye, don't do lots of insult to the eye, and still if they have a redness, drop in the vision, pain in the eye, then immediately they should report to you. Or if you are apprehensive and scared, then treat this patient and don't allow this patient to end up in a blebitis or an endophthalmitis. Otherwise, it's very, very difficult to treat these patients and conserve the vision. So this problem you faces very often. It is very rarely that you faces the problem of a hypotony in the early postoperative period, but the late postoperative is a very challenging, and most of the patients require the revision of the surgery. But if you do the revision of surgery, most of the time it's pretty rewarding. Thank you very much for your patience hearing.